So if you see, there is an 86-year-old male who has had progressive dyspnea with NYHA class 3 symptoms and lightheadedness for the last 6 months. In the past, he has had AVR as well as the atrial appendage closed with AtriCure device. A year after that, he had pericardectomy for constrictive pericarditis and pacemaker. Continues to have atrial fibrillation and has symptoms now. With the pacemaker is a VVI paced also. So he has an aortic valve prosthesis. We are going to show you the echo. He has a mixed prosthetic valve disease, moderate AS and moderate AR also. But more important, since he has ongoing symptoms, with the imaging that we have done, we felt that he need to be taken care of. Of course, he has some moderate to severe TR. So this is, you're going to show the echo?
I can show echo.
Yeah, show that live echo, yeah.
Okay, so this is live. This is TE image. You can see overall systolic function is normal of the LV, dilated left atrium. He doesn't have any significant aortic insufficiency in this view. On short axis, you can see that two of the leaflets, they do appear like they're moving, but they're very restricted in function, causing stenosis. And again, no significant aortic insufficiency in the mid-esophageal windows. We measured his LVOT diameter to get an AVA. These are his
all of them
velocities.
in the room.
This is a low flow state. And his AVA is calculating to 0.8 with an indexed AVA of 0.4. His stroke volume index is 19, and his dimensionless index is 0.23. This is consistent with D3, so low flow, low gradient, paradoxical. And in the transgastric views, you can see there is actually a little bit of valvular AR, but no PVL.
Maybe actually we can get some opinion from our panelist, because this happened many times. The valve is 8-10 years old, only 1 or 2 leaflets are a little rigid, and some echo shows moderate to speed velocity of 3.5, some show 2.5, and only little bit of AI. What do you do in that situation? I mean, you could wait, or should be, when patients are symptomatic, should we go ahead and take care of it?
It's a great
that question always comes.
Yeah, it's a great question. I'll start with Amit. You know, it's, do you think you need more imaging, or is this enough?
I think
We have more imaging done, right?
Yeah.
We can go back to the slides.
No, sometimes
Yeah,
it's
this
hard
is
to
the
tell just
CT
how
scan.
bad the valve is when you think you see some of the leaflets moving, especially in these surgical valves. They're so hard to be sure of what the problem really is.
No, I think that's absolutely right. And I think that for me, if somebody like this didn't really have much in the way of symptoms, but I had an echo like this with these parameters, I might be more inclined to sit tight and wait. But especially in the presence of symptoms, if you have something that you can do to make them feel better, I think it's, in general, I tend to err on that side more than
Akil,
anything
does
else.
4D CT ever help you determine a better answer?
You know, when you have these surgical valves, I think it becomes challenging. What I like to do is look at the temporal trends of the gradients, the DI, the acceleration time, the AT over ET, to see how those progress and correlate that with symptoms. And so if the patient's symptomatic and those parameters are suggesting that there's dysfunctional valve, there's certainly some PPM, I think it's reasonable to treat these patients.
Okay, we agree with you.
All right.
Great.
Okay.
Yeah, so you can see the
scan.
CT scan is a 25 Magna East valve. So you can see the internal diameter is around 23, 22. You can see LVOT. Oh, we lost the slides.
Go back to the slides. Yeah.
Yes,
Oh, there we go. LVOT is bigger, you know, considering with next slide. So you can see, you know, the STJ is not bad in terms of dimensions, but you can see on the bottom left image, the VT STJ about the STJ is only 3.2. Low left main, very consistent with a surgical supraannular replacement. But more worrisome is the right, actually, and we'll show you the angiographically what it looks like and why we are worried. And then you can see here the aorta is not that horizontal, which is always helpful. Next slide. And you can see now, again, looking at this view, this is kind of top of the commissural post, but the leaflets will be deflected. You can see this is 23 circle where the leaflets will end up maximally displaced. And you can see that here the distance is not that great in terms of the above the coronaries. Next slide. You can see this is how it looks, and what we decide here is going to use a balloon expandable valve in this case.
Gilbert, you briefly showed us an image of the coronary angiogram. I find in these kind of cases, not so much that you're looking to go fix the coronaries, but you like to see where the coronaries come off from an angiogram standpoint. So it's nice to see where is the LAD cannulated and where is the right cannulated.
Sure, Steve, great point. We're going to show you that once Gilbert finishes with the CAT scan.
Okay.
Yeah.
We're done.
You done? I know, they probably, did you guys hear
So-
Gilbert Tang?
Oh, yeah, we heard the presentation. It was great.
Okay.
Great.
Okay,
Can
good.
we go to
So
the-
now we can show the angio?
Good, yeah. So let's start with the left here. So you can see the left coronaries are pretty much non-obstructive there. Here is the LAD, some mild plaque, nothing serious. The RCA is the area of concern, and Steve, I think Gilbert showed you on the CAT scan as well. It arises from below the stent frame, so whenever you put a valve inside, and that's why fracture becomes very hard, because it increases the dimension of the new valve and decreases the VTC, so makes it harder in these cases. And here is the RCA takeoff. You can see it right below the stent frame. So for me, the RCA is more concerning. The left, I'm not really worried about. And I can show you in an aortogram as well. You see how much clearance you have on the left and barely any clearance on the right. Does that help you?
That's terrific. So now you have a real problem on your hands of what you're going to do for leaflet splitting or modification or protection of especially the right coronary artery leading up to this implantation. Eberhard, what would you do to this right coronary artery?
Yeah, I think this is a very interesting case, and I think I do agree that the left is not so much concerning. I think the right is more concerning. The one thing that is, I think, in favor of valve choice, as far as valve choice is concerned, is this gentleman is 89 years old, so we don't have to worry too much about things that we would worry about in a valve-in-valve or TAVR and SAVR with the younger patients. So that, to some extent, is a little bit in favor of the procedure, but nevertheless, the right is concerning. As far as the valve choice is concerned, here I would argue that it wouldn't make too much of a difference which valve you're taking, a balloon expandable or self-expanding, given the facts that I mentioned before. The splitting, the modification, leaflet modification is an interesting aspect. It would complicate the situation a little bit more in this gentleman, but I think it's a very, very great and very interesting case.
Ask them.
So Sahil, take us through your thought process.
Yeah, sure, Steve. So again, the access was pretty tortuous here. I'll show you. Extremely tortuous anatomy, and I don't know why all cases today have been giving us little
New York.
grief. So, yeah, you can see it here, right? So
Wow.
this one I did do a wire protection. It was just horrendous. So I put a wire across just in case for a bailout, got the access. Everything looks pretty reasonable so far. Once we had the access, take the angiogram, which is a standard procedure for all our valve-in-valves, especially the high-risk ones. We do an angiogram, delineate the coronary anatomy. CT is helpful, but I think angiography is the main stay here. And then crossing was pretty easy here. Unlike the last case, it was not an hostile angulation. The sinuses were really in line with the valve itself. So an AR2 catheter diagnostic just slipped, the wire just slipped through. It was pretty easy. Got through, swapped out for a pigtail. And here we are, and we will go with leaflet splitting. The question for the panel is, should we do just the right or should we do both because we have the device?
Okay. Hassan, what do you want to do?
I think you get one for free, so you might as well do. The speed of it's an expensive device, but one of the big
talking about
advantages, one of the big advantages. I'm assuming that you're using Shortcut. Is that right?
Yes.
I think I had a leak. There was a leak.
Okay, all right.
So from that perspective, I think it has. I don't know if others have comment. If it was a Doppio Basilica that adds a different discussion because they're technical.
So if you're gonna do this,
aspects.
if you're gonna do this, Hassan, are you gonna go to the right first, just in
Yes.
case things go
Yes,
downhill?
because that's your primary, there's significant bias in this frame. So I think that is your primary goal, to do the right first. And I think the second one, there are theoretical benefits in washout, remains to be seen if that is the case. But I think doing two, because you're just essentially rotating it, the left is much easier than the right even.
I mean, did you see anything on this CT that makes you think that shortcut won't be ideal?
Not off the top of my head. I mean, I think the fact that, so the things that you oftentimes worry about is if the leaflets are heavily calcified, or if there's an
What's
issue
the
with the
ACT?
aortic angulation. But the leaflets here actually seem pretty ideal for that sort of thing.
What sheath do you have in right now, Sahil?
It's an E sheath. It's an E sheath.
Okay.
Standard E sheath. Yeah. Go ahead. Go
You
ahead.
want to talk about this device for us and what your plan is?
Sure. Yeah, I totally agree with you that we should do the right first. And the device, again, it's a mechanical splitting device. Jafar showed some great slides in his lecture in the morning.
And what wire do you have in the ventricle right now?
Standard Safari wire. Go in.
Okay.
Go in.
Once in a while, I find
good.
that Safari doesn't have quite enough strength to help me with this device. I prefer a little bit of a stiffer
down.
wire for this.
Keep coming. Keep coming. Keep coming.
So as you know, the shortcut is kind of a
Okay, go ahead.
development out of
Good, right?
the Leaflex, which has some specific designs, and you can see the stiff part, the dark part. So you need a certain height of the ascending aorta, and then he probably talks more about it. But there are some different mechanisms. Now he's opening up.
Sahil, you want to tell us what you're doing?
Sure. So as you see here, we've unsheathed the device on the valve. Bring the sheath all the way up. That exposes the splitting element. Then we bring back the nose cone slightly, retract the nose cone. And now the question was, we wanted to do the right first, correct?
Correct.
So right now it's settled for the left. I think we can move it to go to the right here. So, yeah. So we're just pulling back slightly here. You can see that.
So what view
And
do you
I'm just
want to
gonna
be in
rotate
to
the-
ensure
sorry.
that you're in the right?
Good. Stop.
We go to RAO.
Okay.
And we'll add some flex. Yeah, sorry, just I'll answer you one second. I'm going to go to the views to show you exactly where we are. So I went from LAO to RAO right now. It actually looks pretty. Go in.
Okay,
go
I'm
down.
going in.
Yeah, good, stop
Okay,
here.
Yeah. Huh?
Okay, Ari. Yeah.
Yeah.
So what I'm doing is to get to the proper CT angle, which.
Can we remove the TE up?
Yes.
Lucy, we can remove the T
Yeah.
now.
There you go. This is the angle.
Yeah. Keep it there, right?
How hard do you work to try to make sure you're directly in the middle of those commissural posts?
I am doing that right now. You
So-
see, I'm working really hard.
So one thing you need to know is that where does the coronary take off, right? Is it the middle between the two commissure or not, right? Because you might have to sometimes deviate. And you can, if you remember the slides, thankfully this one it is in the middle.
So
you
you
can see
see,
that here.
we are right in the middle here. So I did manipulate the device a little bit. A little clock on the green knob really helps you. You don't want to rotate too much.
And when the coronary, you guide this according to where the coronary comes off, correct? Rather than just in the middle of the commissural post, is that correct?
Yes.
Yeah.
Okay, so let's go to our view. Little LAO view here just to get perpendicular so we can see the actual splitting. What was our view for the LAO? Come, Cardle Gilbert.
Yeah.
Do you ever do an injection at this point in time to see where the coronary comes off? Is that ever helpful to you, Sahil?
Great point. So that's going to be our next step. I just want to get to that view where we are perpendicular. The pigtail's already there.
Take a cine.
Okay. Now,
Don't see it.
so we don't see it well here.
The pigtail is probably in the non-cusp,
I just want
non-corner.
to go down a little bit first. Go down with the,
So Gilbert, can you, while you're doing this, when you split, can you tell us what and how you're doing this, the splitting?
Yeah.
yeah, you can see the leaflets. I want to show you this, 1 second.
Yeah.
Steve, do you see it now?
Yep, yep. It looks like you're in really good position right there.
Yeah. Go in a little bit. Good. Maintain tension there.
And what are you doing on your handle right
say
now,
that.
Sahil? What are you
So I'm
moving?
actually activating the device, so the blades actually make contact with the splitting elements.
Listen it up.
So,
Good.
so
you
I'm
can
gonna
see,
push the wire
actually, it's
first.
very important. Can we just show it again?
Sure.
That the blade needs to engage to that thing. Sometimes when it's very calcified leaflet, it might not.
And
See
you
the
ha-
blades there?
and you have to make sure that blade doesn't miss that other element, or else you could have a real problem with this device. So it has to be
Yeah, and you want to
engaged
be at,
correctly.
yeah, and you want to be at the base as much as possible. Now remember, there's a sewing ring that is fluoroscopically, you can't see it. It's thicker than the line that you see. So sometimes you try to engage, but you actually keep hitting the actually fabric portion of the valve. So we've had some situation like that. And when you do it for
push the
TAF in
wire.
TAF, that's even more challenging. Okay?
no
So just be
flex.
aware of that.
Sheath the system. Yeah. So you can see we push the wire, so it is always from LB to aorta. So push the wire, so it stands up the device, engages the leaflets. Take the flex off and resheath all the way. Yeah.
No.
Away from you.
so
Yeah, keep
no,
going.
no, it's not coming
Keep
back.
resheathing, keep
Okay.
resheathing. Go, go, go. Good stuff.
Okay, good.
Okay, I really like it, so let me do it under cine.
Here's the moment of truth.
Advance the wire, advance the wire, advance the wire.
Yeah.
They're pulling pretty hard right here.
Yeah.
The good news is I don't see the aortic valve
Okay,
move.
stop.
That's when you know you're really pulling hard.
Yeah, so ideally it should just be.
Pop
uh,
off,
Yeah,
yeah.
Wire is in the wrong.
Okay, let's readjust
maybe
now.
there might be some interaction with the.
Yeah. I would disengage the blade. So I don't think it will
May not be.
actually cut.
So the
Lucy, can you show me on TE where you are?
Yeah, I'm
Just on a
showing
short axis. So where are we?
Right here.
Let's re-engage.
Are we close to the frame?
You are. You're very,
Yeah, that's what I
you're
thought.
It's
very close to the
rotated.
frame.
It's rotated.
Re-engage again.
Okay, now,
Yeah,
a little bit better.
this is better.
Try here.
Advance the wire.
Yeah,
Do you think we actually have the splitting element?
yeah.
You think so? Yeah.
Wow. Yeah, no, it's the frame. Will you see the frame on the
Yeah.
other side?
Yep.
Yep.
Looks like
Okay,
you're trapped
so-
in there. Yeah.
Good. So this is what I'm gonna do. We're gonna reset the system.
Yeah.
Good.
Take the blades back, reset the whole system, go back in, and readjust. Okay, and we'll ask Lucy to show us on TE where exactly we are.
We can go back to the other view too to see.
For
make
what
sure
it's
we're-
worth, you did cut something.
We did cut something, yeah.
It's right
But-
here. You could see leaflet motion.
So see, you low off
Show
here.
you.
So do you think that's, so let me ask you
Right
this, do you
here.
think you're good enough there? Do you think you've done enough?
No,
See this? This is new. You cut this right here.
this is better, right? Lucy, where am I right now? Can you show me?
Yeah.
Amit, do you think they've done
So
enough?
you're here.
It's
You've
tough
cut
to
this,
say.
Sahil.
I mean, certainly it looks like there's a little bit more AI,
You're
you know,
not.
unless it's all artifact. And
What's
so
No.
I think it would be
I don't
nice
think
to
that's-
have sort of a more definitive
There you
Okay,
go.
much
laceration.
freer now. Good, let's check now.
Yeah.
That's a better position in my mind.
I actually like it there.
It's on false, right? Remember?
Lucy, this looks much better now.
Yeah. I think you cut something. You can see that leaflet is moving. It's
Is that the
moving more freely,
right
and
blood
there's
pressure?
AR here that there wasn't before.
Where is
Blood
it going?
pressure.
Blood pressure is fine.
Okay,
Harry, can you support?
I think let's take this then.
Just kind of
You're
shift
not
it down.
below, right?
Hmm,
You're
pretty
not below.
deep there.
1 second. Yeah. Yeah,
Okay.
much better. You see that? Yeah,
Yep,
that's
There you
it.
go.
Okay, flow safe.
Fluoro
that.
safe. Good. So this is what I want now, guys.
Go
Don't
to
want to go
LAO.
for the left.
Yep.
I'm going to fully deactivate the system. And we want to go with the valve now.
Is your blood pressure,
slightly low.
is your
It's
blood
slightly
pressure
low.
still good?
It's been low. It's been low like this,
No, no, it's
so
been
I'm not
low.
worried. So,
Yeah. Come down.
Resheath the
Perry,
system.
can you support?
Okay, yeah.
What is your blood pressure on that side?
Our blood pressure's okay over here and at, the-
No, 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 we are asking the anesthesiologist in the back.
oh, okay. I thought you were worried about my panel.
Good.
Pace at 100.
Good. Lucy split is good. Yeah,
Yes,
you can
that
see it.
helps.
Beautiful.
It looks good,
Yeah.
yeah.
I think we go for the
Okay,
valve
okay,
now.
come.
Why don't we just there?
Let's go for the valve.
No pressure.
So not going out to the left side, is that right, Sahil?
I think so. I
Okay.
think the left is pretty good. You've got a nice split. I think
Yeah.
safety first, right?
Correct.
Pressure is on lower side now.
Can you pace at 100?
Get the valve.
Are you pacing just because of AI, Gilbert?
Hey, you get.
Yeah,
the-
we were,
hey,
but it didn't really
leaflet is-
change. I was
yeah.
hoping that it would
Yeah,
come up a little bit better.
That's leaflet.
The-
Let, let the drugs kick in as well, that
leaflet
anesthesia
is
is
here.
pushing.
Leaflet is here.
Yeah,
Okay,
you
give me the
have
valve.
Moderate to severe AR.
Moderate to
Here,
severe.
quickly,
Yeah.
quickly.
Yeah.
There's a piece of the leaflet there.
We
Gil-
saw some goodies on our
We'll
way.
show it to you.
We'll show it to you.
Yeah.
Later,
Hey, Gilbert, are you pacing off the wire all the time on all of your cases?
No, we have a TVP. We have a TVP. You see that
Okay.
on the fluoroscopy.
Who paces off the
Yeah,
wire
we're
on
gonna
this
fix it.
panel?
We're going to fix it.
Severe
Does it
AR.
show AI?
Severe AR.
Moderate to
Yeah,
severe.
we'll fix it. 1 second.
That's okay.
Not for
Push the wire.
An issue with
Gilbert, come on.
with
Yeah,
the
Gilbert,
pacing
come on my
circuit,
right
just
side.
institutional preference.
Oh, okay.
Yeah.
That's fine.
Wire.
Yeah, I have it.
Good.
Go.
Go.
What's
Full,
fine?
full,
Keep
full,
going.
fully
Keep
flex,
going.
fully
Keep going.
flex.
Keep going.
Flex,
Keep
flex,
going.
go.
Keep going. Keep going. Keep going. Good. Okay.
Okay. Oh, remember, we want to deploy a little bit deeper, right? We talked about that. So a little bit.
That was a
higher.
real split.
Yeah, it's called, it's an intraleaflet removal, cathedral.
Okay, let's.
Wow.
Jaffa would have been proud.
So
Base
why
180.
why do you want to employ,
You want this
why do
way?
you want to implant deeper?
Because of the inner skirt, it might still obstruct. Go.
So your goal is just to line up the outflow, basically.
Yep, correct.
Go, go.
Good.
Good.
You understand, right? Half the sapien ultravercilia is
Back up.
inner
Back
skirt.
up. Back up. Okay.
Yeah.
Give some meds. Resuscitate.
At 1 cc.
Good job.
At 1 cc.
Yeah, wait few seconds, let him recover.
Yep.
I like how quick
Sometimes
your
just-
deployment was. I'm a big fan of fast deployments.
Well, this case, there's no blood pressure. It doesn't really matter. We need the pace. So,
The pressure coming up, good.
But you guys understand what my point is, right? We were concerned about the
Yeah.
inner skirt. If it goes up, would still obstruct
Base
the right.
180.
Yes, yes.
So everyone agrees with my
go.
decision not to
Yeah.
lacerate the left?
Yes, that's a great
Yeah.
decision.
Good.
It looks
We
better
don't
and
know yet.
better all the time.
Yeah.
Well,
And
Gilbert, you're so
back up
fast.
now.
Say it again?
You're so fast.
That's good.
Just interesting.
Push the wire.
Yeah.
Good job.
Get a hemo, get
But did
a
you
pentail
really-
picked up.
Yeah, everything's done.
Pressure came up.
Beautiful.
Very good.
Mm-hmm.
All right, Lucy, you want to tell us what you're showing?
Yep, so I'm just checking the valve with color. I know the pressure's on the lower side, but
Look,
there's no
it's very good.
PVL on my sweep here.
Yeah.
in the
Systolic, we have at
midesophageal.
100 now on our book.
Give me a
And
picture.
consistent with what anesthesia has. But yeah, no, this is a very subtle
ready in the
thought.
other
You know, I always, when I give a leaflet modification talk, people say, oh, you lacerate the leaflet or whatever, and then you can implant however you want. Not true. If you have commissural misalignment for a 12 valve, that commissural will plaster against that split portion.
LB looks
With a,
okay,
with a
Lucy?
balloon expandable
checking
valve,
now.
half the cells of the whole valve is actually covered. You cannot modify that. So if you implant a little too high, that part can still obstruct. So you
LB's
actually
normal.
Beautiful.
have less of the spray and the split than you actually have. So this is just an intentional deeper deployment, which is not people want, but I think out of necessity and safety, I think that's the right thing to do. And I can tell you that now you can engage the right should be okay, because actually now you don't even have a right leaflet or party.
can Lucy-
side.
Right catheter, diagnostic JR.
Can Lucy show us the flow in the right coronary artery and the left main on TE
Show
echo?
the hemodynamics, please.
Where's the
Sure.
tissue?
Okay,
Pressure
let's,
I'm
is
just
very high.
getting a velocity right now across the valve.
hemodynamics,
Mean
please.
gradient is 4.
Where's the tissue?
No PVL. Let me get you those.
The cost of the
coronaries.
lower implant is, I guess, somewhat modest because the surgical frame is going to protect you from
Yes.
risk of
Guys, show the
pacemakers. So I
hemodynamics,
think
please, one side.
Hemodynamics sort of notwithstanding, maybe there's a difference there, but
Great
otherwise,
point.
I don't think that it costs you much to deploy a little bit short.
I agree.
shallow.
No gradient.
I do think this lower implant is the way to go in this case, no doubt.
Beautiful.
So there's the
Let's
left
do an
main. I
aortogram.
don't know if that-
We
All
can't
right,
see,
so
we
where's
can't,
the
oh, there we
camera?
go.
You
Show us,
only usually see this in the operating room, not outside, not on the cath lab,
A
okay?
complete leaflet is outside, guys. Camera?
So show it to Jaffer, okay?
yes.
Can we
He would be proud. Can someone zoom in the camera here?
zoom in on the camera, please?
The overhead camera or whichever?
No, they'll do it. They'll do.
There's the right.
Oh,
There's flow in the
geez.
right.
Holy moly.
Yeah.
Can you see it? Can you see
Yes.
it? Zoom in?
Now you
zoom in.
understand why hemodynamics are important during deployment?
Yeah. That's the
Don't try
right,
that at home, okay?
yeah.
No, but let's see if
Better out
Jafar
than
is
in,
on the,
that's for sure.
on the panel or so. So I'm sure with the shortcut, are you still doing Basilica or I know there's a cost involvement here.
He only does Basilica.
Yeah.
Hey, why-
It's telltale. The telltale is FDA
Hey,
approved now. so-
Gilbert, why did you get that piece? It's only supposed to split it. It's not supposed to capture it and retrieve it.
No, correct, but remember, we had one split first, I think the first time, and
And the
this is a
second was at
second
the-
split.
yeah.
So when you have two split, you have a V and you take out the whole tissue.
But
It's like you
usually
have
don't
two-
hold on
two-
to it, yeah. You're lucky to
Yeah, no,
hold on to
but
it.
thankful, exactly, that's exactly the point, that when you resheath,
Contrast.
we're able to actually recapture it in the distal rather than going somewhere else that you don't want to go.
Because that definitely could have gone north.
Yeah.
Yes,
That's why better
Look at
out
that.
than in.
Yeah.
Look at the RCA, LCA flow there.
you
Beautiful.
guys see it in the
Aortogram?
aortogram, the right
beautiful.
coronary flow?
It's beautiful.
Fantastic.
I think
So
I
it's
like
almost like
I like the echo images of the right coronary artery a little bit better than that whiffogram there, though, Gilbert.
No, absolutely. So that's why we do these procedures under GATE. So actually, you can confirm the flow. In this case, this is very important, I think, in our opinion.
Let me ask you another question. What is the prevailing thought process in this leaflet, cut modification in terms of the cerebral protection device, Sentinel? Are we people using, favoring,
You're
every
supposed
case,
to get
no
it.
case?
Hassan, what do you think? Do you think
Yeah.
should all of these people get Sentinel?
It's still debated because it's a clean cut, but say, like in this case, I would, in retrospect, definitely have put in retrospect. But we are using routinely Sentinel in every shortcut.
We don't use it, we don't use Sentinel, but I will tell you, Gilbert, after you guys pull that piece of tissue out, that gives me pause, especially if you're gonna do two cuts
You're
on one
supposed to do
leaflet like you
Sentinel in
did.
this case.
No.
Pretty impressive.
Yeah, well, I think the reason why we tried
Not
to,
this
we
one.
weren't, we weren't actually sure we had the first cut. There was a little bit, but not sure if that was sufficient. Lucy showed us nicely that there was a new jet, but we weren't sure this is deep enough to actually create the V. Remember, that's a spray. You need the spray to be able to maintain the perfusion. So yes, this is a little bit more gutsy maneuver.
I think.
But there was also a lot of resistance on the first time, and you just don't know where you actually
Yeah,
get caught.
I think
So-
that frame interaction may have
Yes.
made it not so clear, but I think with the Pro, when it comes, it'll be much easier to see a
Yes.
full cut. Yeah.
Because you don't need to pull anymore.
Don't
It's like
need
a
to pull.
switchblade. You just basically, you just press the button, slide, and the cut happens.
Your team did such
So
a
it's much more stable.
Your team did an unbelievable job, first of all, to get all of this done in the time frame you did, but there's so many things that you taught us, like where should the leaflet splitter be to be in the right spot, how deep you need to be, not to be afraid to do the second cut. And I do think that capturing the leaflet and showing that to us is a big learning help for the whole audience as to what can happen during these cases. And then the speed of implantation when you get severe AI was really impressive. Next of all, Gilbert, you emphasized several times the depth of implantation with the Resilia S3. Do you want to talk about that one more time just to reemphasize that point?
Yeah, so if you look at the Resilia valve or Sapien 3 valve outside the frame, only the top row of the hexagons is open. The rest actually are covered. So if you implant high, whatever is below the bottom half will cover the split portion of the leaflet. And that can still risk sinus sequestration or obstruction. And people don't realize that. The other point that we also know is that there's no active commissure alignment with the Sapien 3. So the commissure tap sometimes, if there's very little room, can also be a cause of obstruction. So those are two things that the audience and others, operators should be aware of.
And
So some back-end story, Gilbert and I were discussing this in the morning, and we wanted to go frame to frame, and we were like, let's deploy frame to frame. And then when I took the iodogram and the angiogram, I said, you know what, let's go slightly deeper. Patient already has a pacemaker, is 89-year-old. We're not going for hemodynamics here, we're going for coronary safety. Let's go slightly deeper because we want to prevent that inner skirt issues. Because if there is some obstruction, if, for example, your leaflet splay is not perpendicular, it's more, at an angulation, then at least you can recross and go inside the coronaries and salvage it. So I think that's the most important thing. It's not just
Absolutely.
It's not just doing your procedure itself, but if there's a complication, are you able to bail out? And
Yeah,
and
because
then you have
we
skirt on
didn't have
skirt.
any snorkel or chimney to protect, right? So if you're really concerned, you can do that, but it's not easy. It's a very low takeoff right to be able to wire that. We had trouble one time for a TAF inductor, we couldn't.
Right.
And we had to just went with the case.
so in this
Is
case,
that reasonable?
yeah, oh yeah, I mean, that's a terrific discussion. So in cases where you want to have commissure alignment and you're using an S3, are there any tricks at all that you could use to try to figure out if you're going to be commissurally aligned with that surgical valve? Anything you can do?
Not with this generation. Maybe X4. X4 has an extra wheel that allows active alignment, and there's some new balloon expandable valve as well that has active alignment, but not in current
So in
iteration.
India, my valve can be used, has active alignment. X4 here under trial has active alignment. And the Mira Siegel valve, which is hopefully will be starting the pivotal trial soon, has active alignment.
Yeah,
So,
and do
but not in
AVR
the
as well.
cur- Yeah,
Yeah.
but
And
not
then
in the current one.
The final point is, Sahil, you made a significant mention about how difficult the access is. Are you going to be bold enough to show us how you're closing this groin?
Yeah.
Sure, why not?
Just to say, we will be ready for the next case, and while he's showing the closing, this was a very
40
terrific
per
case. Could have been very complicated, but the whole team made it so simple and great, and just it tells you that how quickly we can do these cases. And you know what is the disadvantage? The CMS is understanding all the procedures with the high RVUs. We're supposed to have 1 hour, now you do in 10 minutes. Your RVUs have to go down. So you know the latest cuts is happening in every aspect with the watchman and now other coronary procedures and everyone. They're decreasing our RVU because procedures are simpler and faster.
I will say though, I
simpler.
think in a case like this, part of the reason why you're able to move so quickly is that it belies the immense amount of technical planning that occurred behind the scenes.
Yeah.
As Sahil was talking about, especially, all of the time that you spent looking at the CT scan, coming up with a strategy for the coronary protection, performing the procedure when things required you to move even more quickly than normal, being able to do that, I think that speaks to not just the technical skill, but really the procedural planning that happens behind the scenes. And, to be honest, I think all of that really is part of the procedure. And, to your point, when CMS looks at this, it's not really just the time in the room, but the total amount of time spent on these procedures.
Yeah, I agree.
So from a closure standpoint, if you see, I always, in the E-sheet especially, I always put the dilator inside because there's always some splitting. When you're pulling a bareback naked E-sheet through the iliac, especially if they're tortuous or calcified, you tend to injure them more. I think the dilator gives you a little more support. So there's a dilator inside, and I'll pull out the E-sheet end block with the dilator inside and leave the wire in. And once we're doing that, we'll pull on the sutures. And if there's some residual bleeding, I'll go up and over. I already have a wire across, and we'll balloon it. Go ahead. Protamine is in.
Always 2 per close, Sahil?
2 per closes, yes. Still old school.
Okay,
Sorry about that.
it's okay. And what do you use for your up and over catheters?
Wire out.
I don't think I've done up and over for a long, long time. I'm impressed here. Do you put a balloon on the other side or just wait to see how
Or
this
some
looks?
pressure. Yeah, so I'll show you 1 second up and over. And I'll tell you my reasoning why I do up and over here. So we have, yeah, hold pressure. Good. Okay. So we have hold pressure. Good. We have 3 fellows here that we train,
Yeah.
and I want them to be really good at endovascular as well.
Yeah.
If they do up and over consistently, they become really good in emergency management. So it's not just doing it pre-procedurally, but sometimes when they go out in practice, and sometimes there are resource constraints, they can really, these skills help them. And if you see here, go ahead with the balloon. Let me show them this. So usually I use an IM catheter, but in this case, there was a lot of acute angulation. Sorry. So you see that? So if there's an acute angulation like that, most sites will not try to go up and over here. They would not do anything. I use a UF catheter. You can also use a peripheral sole catheter sometimes. So UF really gives you a lot of support. Get your glide wire down, bring down your UF catheter or swap it for a Navicross, and then you can go ahead with your V18 wire. So V18 is my workhorse wire in these cases. And if I need to stent or do something, then I'll swap the V18 for a stiffer wire or a supracore and get the case done.
Do you always use a balloon after the case?
No, only in this case, only in this case.
Okay,
I want a perfect closure here.
okay.
And how high are you going up on that balloon? Very
2
low?
atmospheres.
2 atmospheres.
And how long do you leave
Go
it
ahead.
up, Sahil?
3 minutes, 3 to 5 minutes. Go in. Good. Yeah, that's it. All right. So just 2 atmospheres, leave it alone. Some manual pressure on the outside, and we should be okay.
Okay, that's terrific.
Thank you.
Do you ever
Let's go to the
reverse
other case.
anticoagulation?
Always.
Okay.
Unless patient got a PCI during the procedure or
Did
Yeah,
you give
sorry.
did you give protamine during this procedure?
yes, 50 of protamine.
Okay.